Our next speaker is Dr. Tara Gomes. Dr. Tara Gomes is a scientist at St. Michael's Hospital. She's Scientific Director of Urban and Community Health at Unity Health Toronto and Program Director of the Ontario Drug Policy Research Network. She's also an assistant professor at the University of Toronto and holds a Canada Research Chair in Drug Policy Research and Evaluation. Her research program focuses on drug safety and drug policy research, with a specific interest in developing evidence to inform policies that address the ongoing drug toxicity crisis across Canada and that integrate perspectives of impacted communities. Today, Dr. Gomes will be speaking on the Ontario Drug Policy Research Network and the opioid crisis in Ontario. Welcome, Dr. Gomes.
Hello. Thank you for the invitation to be here. Really happy to listen to all of the presentations so far this morning. And I guess I work in a similar but sometimes a slightly different space, in that as I've been working in the area of looking at drug policy, opioid use, and opioid toxicities, the way that I've kind of transitioned from thinking about this around the pain lens to a broader substance use lens has really evolved. And so one of the things that I wanted to do today was talk through a little bit about kind of where we started with this work back in 2008, when a lot of the conversation was first coming to light, at least at the policy level, and with some of the work that we were doing around opioid prescribing and opioid-related harms, and how things have continued to evolve, and how rapidly they are shifting, and how that's been, I think, influenced by and informing policy and clinical responses. And so it's such a complex field, as I'm sure many of you are very well aware, and one that I think requires a lot of careful thinking when we think about best responses and what is actually changing right now, what are the best responses, and how to best support people with pain, as well as people who are experiencing a lot of harms from toxicities, which is an overlapping but not completely overlapping group. So I often start here because this is where I started when we began looking at this topic back in 2008. So when we started with the Ontario Drug Policy Research Network, we're partially funded by the Ministry of Health, and one of the first things that they asked us to do was to look at opioid prescribing, because they were really concerned about the growth in opioid prescribing, particularly OxyContin at the time, as well as reports of increasing opioid-related deaths. And so we were looking at opioid prescribing over time, and we knew that around when OxyContin came onto the market, we started to see this increase in opioid prescribing. I think everybody's very well aware of this. We really saw that growth in the darkest part of this chart, which is the oxycodone prescribing. And so this was originally where a lot of the concern arose around prescribing of opioids, where they fit within management of pain, and how we could balance this appropriateness of prescribing against potential harms. And so what we did at that time was we worked with the coroner's office, and we looked at opioid-related deaths, looked at postmortem toxicology to really see what was driving some of the increased deaths that we were seeing that we were really concerned about. And this is just a line chart of all opioid-related deaths up to 2011 in Ontario, including what substances were directly contributing to death. And you can see around that time of OxyContin and everybody really being concerned about that, we started to see that red line increase, which was oxycodone that was directly contributing to death, which obviously had a strong tie to the trends we were seeing in prescribing. And that led to a lot of what we're still talking about today, which is around these concerns around appropriateness of prescribing, what the appropriate doses might be, and a lot of evidence that came out around that time around what is the best dose to start people on. What is considered even a high dose of opioids? Because at the time in the clinical guidelines, the dose thresholds that were established were based on generally, clinical advice. They didn't have a lot of evidence to support them. And we started to see around 2011, 2012, a lot of evidence come out showing that higher doses of prescription opioids were tied to toxicity rates, motor vehicle trauma, falls. They were tied to actual diagnoses of opioid use disorder down the line. as well as other concerns around, not only the dependence on pharmaceutical opioids, but how we might be over-relying on them to manage pain, and how we can make sure that we are adequately managing pain while also preventing any of these harms that were growing in terms of our knowledge and the evidence, especially at higher doses of opioids. And around that time, internationally, especially across Canada and the United States, and then specifically in Ontario, we saw a lot of changes. We saw new guidelines come out in 2016 in the States and 2017 in Canada that for the first time had more recommendations around doses at which people should initiate opioids, doses beyond which there should be caution applied, as well as a lot of supply side policy responses from governments. So public funders of medications, for example. We saw the reformulation of OxyContin to this tamper deterrent form, OxyNeo. We saw high-strength opioids be delisted from the Ontario formulary. We saw the fentanyl patch for patch program that was implemented to get people to return used patches to prevent people from, misusing them in some way and cutting them up or smoking them or trying to get the fentanyl out of them through other ways. So a lot of the policy responses really focused on the supply side. At that time, we did some work trying to understand, especially around when the guidelines came out, what percentage of prescribing was actually outside of what the current clinical guideline recommendations were, which was one of them, which was avoiding initiating people on over 50 milligrams of morphine or equivalent. And we found that about a quarter of people newly starting opioids in Ontario in 2016 were at that point of over 50 milligrams of morphine equivalent at initiation. So really showing that these guidelines were not really well aligned with current practice, and we heard some of that earlier today in terms of some of the initiatives that have then been taken on in terms of trying to better implement post-surgical and other practices within hospitals and other settings to try and make sure that those quantities dispensed, those doses that are dispensed are lower to try and align better with these guidelines. And so what I want to do now is just talk a little bit about what we've learned since then, because a lot of the knowledge and a lot of the discussion that we have is often using data, in 2016, 2017, but a lot has changed since then. And I think a lot has changed in terms of the toxicity crisis and what is driving that crisis that can not only help us see how we can move ahead, but also can help us understand how some of the things that we actually did in the past might have influenced how we got to where we are today. So I talked about a couple of supply side responses. I'm just going to show a bit of data about a couple here. One of them was the OxyContin reformulation. So, one could argue that the manufacturer of OxyContin really wanted to extend their patent, so they introduced a, tamper deterrent form of OxyContin that was supposed to be harder to crush. You couldn't really dissolve it, hard to inject, to try and circumvent some of these potential ways that people might be using OxyContin in a way other than prescribed. We looked at what happened in terms of overall prescribing of opioids around the time of this reformulation in terms of volume dispensed. And at the time of that switch, so it was really quite a switch nationally where OxyContin essentially disappeared from the market and OxyNeo came in. We saw some reductions primarily in Ontario in terms of total volume of opioid being prescribed. So we actually saw this dynamic of less opioids immediately being prescribed. And in some other work we did where we looked at tapering and rapid tapering, we saw around that time there was some dynamics of a lot of people being cut off from their opioids. So some of these changes in how we provided these medications on formularies and how available they were actually meant that people who were receiving often very high doses, over 200 milligrams morphine or equivalent of opioids, were just simply cut off or had their doses dropped by more than half. We also saw that when you apply a supply side intervention on one product, when there are multiple products within the range of opioids that exist, it also has a squeezing the balloon effect, right? So you see that oxycodone, the light blue line here, dropped, but we also saw that the green line, which was hydromorphone prescribing, increased. It's completely predictable, right? You're going to just switch people from one option to another because people are using these opioids for a reason. They're also dependent physiologically on these opioids. People are going to switch them and transition them between opioids in a class. So if the intention here is to think about, stewardship of opioids and potential harms, just moving people between opioids isn't necessarily going to do much, and it actually has the opportunity to introduce errors when trying to transition between doses, between different products. And so if we look at kind of the broad level of opioid prescribing in Ontario, you can kind of see these dynamics as we extend that first figure I showed further out. So when OxyContin was reformulated, we saw this slight decline in opioid prescribing generally, but we also saw that dark part of the bar shrink. And we saw the next darkest part, which was hydromorphone, start to grow. So that dynamic of, you change one product, people just generally move to another. But then we also saw the Canadian guidelines come out, which had more recommendations around quantity, around initiating opioids, and trying to have more opioid stewardship built into it. And there we started to see this decline almost immediately in opioid prescribing generally across the province. And so the question is, when we have these supply side interventions, when we start to actually try and address opioid prescribing, reduce the opioids that are out there with the concerns that existed around opioid-related deaths, one would expect and hope that we would see a response when we look at opioid-related death trends in Ontario. But this is what we saw instead. So we saw that around 2011, the trends that were already existing in rising opioid-related deaths really didn't change much. But then around 2015, 2016, around the time when the guidelines came out, but I will say not actually directly tied to the guidelines coming out, we saw this massive increase in opioid-related deaths. And the question is, what happened there? Was it the guidelines? Was it changes in prescribing? What exactly was leading to this increase? Because if we started to see prescribing go down, one would hope that we would start to see the harms that we're trying to avoid go down as well. And this is what happened. So I've had to kind of zoom out that last figure. Remember where we saw the red line increase in oxycodone, just to allow the y-axis to meet what we saw up to 2019 with fentanyl, which was that fentanyl, but not prescription fentanyl, but non-pharmaceutical grade fentanyl, entered the unregulated supply in Ontario. And we know that that led to a really potent illicit drug supply and also an unpredictable drug supply, which I'll talk about a bit more later. But also, I think, importantly, it really shows that the timing wasn't great, because this was also a time where people were actively having less access to prescription opioids because there were concerted and based in evidence and best practice, people trying to prescribe less opioids, prescribe lower doses of opioids. There was a lot of pressure from the policy level and clinically to prescribe less opioids right when a time when fentanyl entered the illicit drug supply. And so what we saw was this huge risk of the illicit drug supply, less people actually having access to prescription opioids, some of whom were dependent on those opioids and would go into withdrawal. And so if they moved on to that illicit market, they were in a position where they were now exposed to a really potent, really toxic supply. And then COVID arrived. And so we were already in crisis mode at this point, where we were seeing thousands of opioid-related deaths driven by the illicit drug supply in Ontario, and trying to catch up, trying to figure out what the right policies, what the right responses were to keep people alive. And then the pandemic arrived. And we were, people like myself and others working in this space were incredibly concerned, because we knew that many people who use drugs were really reliant on community-based programs and services. We also knew that changes in where people were in the city, people being taken out of their normal networks of support, could increase people's risk of overdose and using drugs alone. And we also knew that drug supplies could change, not only access to prescription opioids, as people might have less access to different clinical-based services, but also that the way in which products were being crossed across borders, the supply and how it was being moved across Canada could also change when we think about the illicit drug supply. So we were really concerned about what might happen when the pandemic arrived here in Canada. And this is what happened. So that yellow star is my last figure, which was the really top part of the fentanyl line. And you can just see what happened just in the first couple of years of the COVID-19 pandemic, where the number of opioid-related deaths not only skyrocketed even further, but again, this was really driven by fentanyl. And again, fentanyl from the unregulated drug supply. So what we now know, and this is data from that CMAJ paper that was presented a couple presentations earlier, is that opioid toxicities are contributing to a massive proportion of all deaths across our country, and in Ontario specifically. So 1 out of 31 deaths in Canada and 1 out of 27 deaths in Ontario and people under 85 are opioid related now. And if you think about our younger population, people in their 20s and 30s, a third of deaths are opioid related. So this is having an astronomical impact in our society. But again, we have to start to think about what is driving this harm. And it's complicated because it is not just pharmaceutical opioids. It is not just illicit opioids. It is this dynamic that exists between these two markets and how responses on one side can immediately impact the other. So this is my kind of Coles Notes version of what's happening in Ontario for those who don't want to go through a million papers and different work that's being done. But this is to try and reflect the current status, because a lot of the time, even when we see that paper that came out last week from CMAJ and the articles that come out, the picture that you'll see next to it is a picture of a pill bottle, usually OxyContin tipped over, right? But the reality is that almost 90% of opioid-related deaths that were occurring in 2023 involved fentanyl, and not prescription fentanyl, the fentanyl from the unregulated supply. So we have to really reframe our thinking when we think about this crisis that we're in, to not have it automatically go back to prescription opioids. This is right now a harm that is occurring because the unregulated supply is so potent and so unpredictable that people can't manage their own doses, and so they're having accidental overdoses every single day. And it's killing people, and it's killing people because they don't have an alternative to turn to. We do see that still 1 in 10 deaths involve prescribed opioids, although the majority of those are methadone that is being prescribed to people who have an opioid use disorder. So not to detract from the fact that pharmaceutical-grade opioids still do contribute to deaths, but it contributes at a much, much lower level than the illicit supply, and then the other harms that come from that, like opioid use disorder, which we know then people might be prescribed methadone, which has its own challenges, and when people stop methadone and go back to the illicit supply, again, they're at this elevated risk of overdose. We're also seeing that this supply is really changing how people use drugs. And while this might seem more focused on the addictions medicine side, I think it has implications more broadly as well. So we're seeing that there's much more stimulant use and benzodiazepine involvement in deaths. The benzos are actually because benzos have entered into the fentanyl supply. So fentanyl, a lot of people who use drugs will describe it as not having legs. Fentanyl wears off very quickly. And so people will use benzodiazepines or add benzodiazepines to the supply because it can actually kind of lengthen the feeling of the high. So people who manufacture drugs and put them into the supply have started to add benzodiazepines into that supply to try and stretch out the effects of fentanyl for people. But what that does, as we all know, is it's a sedative. It sedates people. People who are using drugs, many of whom are precariously housed, are really worried about their personal safety or the safety of their belongings when they use the supply because they're so sedated. So they start to use stimulants to counteract those sedating effects so that they can keep themselves safe. So you start to see how this dynamic of the illicit supply, its unpredictability, actually changes the way people use drugs and increases that risk of harm because now people are using so many different drugs. What I think is really important about this is to remember that chronic pain is also really prevalent among people who use drugs. So when we looked at people who died from an opioid-related toxicity during the pandemic, we found that about 1/3 of people had a diagnosis of chronic pain, and about 1 in 5 had both an opioid use disorder diagnosis and a chronic pain diagnosis in the last 5 years. So this is also a population that often is experiencing pain, often has opioid use disorder diagnoses, and is trying to manage all of these different diagnoses, all of these different conditions, which require opioids in different ways. So opioids to manage pain, opioids to manage your opioid use disorder diagnosis, and the stigma that comes from being a person who uses drugs and being in pain and trying to access care for that pain and pain relief when there is an automatic association with potential drug-seeking behavior. So this is a really complex situation where we have a lot of people losing their lives who are in pain, many of whom who have opioid use disorder diagnoses, and about 60% of them who've been prescribed opioids as analgesics, so opioid analgesics in the last 5 years. So have also been prescribed opioids at some point in the not too distant past. So this is clearly a situation where the people who are experiencing harm, even though it is dramatically being driven by the illicit supply, are also engaging in our healthcare system around pain, around being prescribed pharmaceutical opioids, analgesics, and we need to think about how we best support all of those needs of people to help keep them safe from their substance use, also help manage their pain and manage their diagnoses of opioid use disorder. So So this is just a slide where I kind of flip what I had on the last slide to talk a bit about, how we can use this to inform how we move ahead. So I think a few things to kind of think about are that we have this combination of multiple substances being used, so benzodiazepines and stimulants with opioids. And I don't think what's being appreciated enough clinically right now, and especially if you think about people with opioid use disorders, people who regularly access this drug supply, is that they are now physiologically dependent on benzodiazepines as well. So if they are coming in, they also have pain, they might be started on methadone or some kind of opioid agonist treatment to help manage their opioid use disorder, maybe their pain as well. If that benzo is not replaced, people go into benzo withdrawal and go back to the illicit supply because they have no other choice. And so we have to remember that what's happening on the dynamic of the illicit side actually impacts what happens when we think about prescribing and supporting people with substance use disorders. It's also important to remember that not everyone who dies has an opioid use disorder diagnosis. About a third of people that we see who are having opioid toxicities right now don't actually have one of those diagnoses, and so we also see this impact of people who are occasionally or recreationally using drugs and that toxicity of the supply impacting them. So again, it's really complicated. We can't just think of this with a pain lens and addictions medicine lens. We have to think of it from the broader public health and community health perspective and all the various needs of different people at different points of time in their substance use. And then finally, we know that there are different populations that are disproportionately impacted by these harms. People who are vulnerably housed, which I already spoke about, and the way in which they might use substances differently to try and keep themselves safe when accessing a really unpredictable supply. We know that the substance toxicity crisis is disproportionately impacting First Nations people. And we're seeing this growth in our younger populations. As I mentioned before, a third of deaths happening in some of these younger populations being opioid related. So there's a massive dynamic here of different populations who are also being disproportionately impacted and how we can respond and make sure that the types of responses that we provide are meeting the needs of everybody. And this is just, one of my final slides thinking about how we consider policy and clinical responses within and between populations. Because we have people who are using opioids for pain, people who have opioid use disorder and need treatment to support that. And we also have people who are occasionally or intermittently recreationally using drugs, and they also have needs and need to be supported. And there are different responses that are needed within each of these different buckets. But we also have to acknowledge that these are not mutually exclusive groups. There is a huge amount of overlap, which we've already heard about today, between these groups. And so understanding where there's intersection and how implementing a change on one side can actually have downstream impacts for other populations is really important. And it's something that I have become increasingly aware of over time. And I think in the past, some of the work that we did and the work that came out of some of that in terms of policy response was so focused on one area that we didn't adequately acknowledge and recognize what some of the other implications could be for people. And so it's been a learning experience, I know for me, and one that by working with people who use drugs, people with pain, and understanding from them, their perspectives, and these dynamics, often these were really predictable if we just spoken to the right people and understood how all of these policies really interplay with one another. So I think I'll stop here, which is to say that as I've been trying to think more about policy responses and how to adapt to what is happening right now, I constantly am grappling with trying to think through the implications of are we harming or are we helping? So how do we think about, clinical guidelines, for example? They make a lot of sense. They're based in evidence. They promote appropriate prescribing. But we also know that sometimes when applied in a very black and white fashion, can promote rapid dose tapering, which can push people to this illicit supply, which can make their risk of harm actually much higher and can be hugely dangerous for many people. We also know, as I mentioned, around these supply or prescription-based policies that a lot of the work being done around initiation, I think, is really valuable because that's really this kind of upstream place where we're trying to prevent people from having that first exposure, having these large amounts of tablets in their medicine cabinets or being prescribed them and thinking that they have to take them daily, as we heard earlier, when they don't actually have to. So there's a lot of benefit there in preventing some of this downstream harm. But it also means that when you implement these to people already exposed to opioids, you have these issues of people being pushed between supplies, from a known pharmaceutical opioid with a known dose to a supply that they are unfamiliar with a dose, potency, and content that is very unpredictable and can be very dangerous. And then during the pandemic, we learned a lot. We learned that we can respond very quickly to things. We learned that we can adapt how we provide treatment, how we integrate some of these types of services in virtual and brick and mortar type settings. And that can actually have benefits. So we learned, our treatment system actually evolved in some ways very positively. But we also know that when we don't think through the downstream effects of some of these systems that are put in place, it can actually introduce harm. So one example of that is we had these hotels that were put in place to provide emergency shelter during the pandemic. They didn't have harm reduction built into them. And we saw a massive spike in opioid-related deaths in hotels because people were in a room, they were told not to be around other people, and they were using drugs alone. And they didn't have the same kinds of supports and networks that they had before. So as we think about these kinds of responses, we need to think about how we integrate pain management, addictions medicine, and harm reduction into all of those spaces that we create. So I'll stop there. I don't know if we have time for questions, but.
That was really important for you to speak because on the pain side, we felt the ramifications of that early policy work that was so focused on the prescription pad and eliminating the opioids. So thank you for actually pointing out the interplay here and the fact that when you're creating these policies, there's a certain population of patient that we have to keep in mind. And so part of the work here and some of the, we're going to talk about the Coping Well project that we're really proud of that we'll showcase this afternoon, is how do we start putting in those upstream changes when you're dealing with these regulatory processes. So you've got the harm reduction, and you've got the safe supply on one side, you've got the pain piece, and you've got the patient on 60 milligrams of opioids that now gets a lecture every time they go to their pharmacy versus handing out 3 grams on this side. And so what are some of the angles you can look at to help the upstream side is kind of, can we shift even more focus to the upstream side? Because we can keep throwing things, I think, at the harm reduction side, or we have to get a balance is what I'm saying. So what are the policy changes that you can see?
It's a great question, and I think part of why there's such a focus on harm reduction right now is because people are just trying to keep people alive. Right? And so I think when we're seeing so many thousands of people die across the country every year, it's easy to just focus on how do we keep people alive. And I think that's why there's such a focus. And I think it's an appropriate focus right now because of that loss of life, but we can't be too short-sighted and only focus on that, because we do know that, when I speak with people who use drugs and people who are accessing this illicit supply, I wouldn't say all the time, but a huge proportion of the time, people say their first exposure was through, a dentist prescribing them, or, having some sort of surgery or something else happen, and they got prescribed opioids, they got a lot of them, they really liked it, and there's a bit of a domino effect. But we also know that it's not only over prescribing, it's also that some people take opioids and really like them, and they really like them right away. And so it's also around that education piece, and having more open conversations around substance use. I think that there's there's obviously a lot of stigma, and I think that that stigma kind of infiltrates not just society, but also our healthcare settings and how we talk to people around substance use, how we try and help them identify what different options might be available to them, and all of that can happen on the upstream side, right? One of the earlier presentations today talking about, that education piece, when you provide that first prescription, helping people understand, the risk-benefit profile that you can use this to manage pain, but, you don't want to just have 30 of these or 50 of these sitting in your medicine cabinet, that it's not just small children at risk, it's also, adolescents and young adults who might be using these substances. All of those are conversations we can have upstream, but we also have to think about mental health. About 95% of people who lose their lives from opioid toxicity have a mental health diagnosis. We need to think about people who are precariously housed. Those are other upstream things that, and responses we can think about as well. So how do we better support people in their mental health? How do we think about the experiences of trauma and anxiety that people have that can contribute to harmful substance use, whether it's from the pharmaceutical or the non-pharmaceutical side? And how do we also support those social determinants of health, housing, employment, all those other social determinants of health that can also help support people so that they can kind of manage all of these various circumstances that they're in and not have to turn to substances to try and deal with some of that hardship that they're experiencing. Yeah.
Thank you, Dr. Gomez. I just had a question about if you had any comments or any lessons learned from, in Oregon, Portland, Oregon, last year there was a look at, I may be wrong in terms of stats, but there was like somewhere around 500% increase in opioid-related death after they've decriminalized opioid use. And I was just wondering if you have any comments on that, why that is, how we can learn from that for here.
Yeah, so I think, so we also have in BC, there's been decriminalization of substance use as well. One of the things that, a couple things. So one of them is, in Portugal, opioids were also decriminalized many, many years ago, and it has seen a lot of benefit from that. So I don't want to overinterpret some of the stats that have come out from Oregon, but the other piece around decriminalization that, I don't know, maybe some people will find this controversial, is I don't actually think decriminalization is going to have immediate impacts on opioid-related deaths. That's not really the point of decriminalization. Decriminalization is around the criminalization of particularly racialized people who use drugs and end up within the incarceral system and have all of the downstream negative impacts that can come from that because they have drugs for personal possession. And so I think it's a little short-sighted of us to assume that by decriminalizing opioids, we're going to immediately see a benefit on the opioid-related death side. I support decriminalization. I think because of the broader implications of criminalization of substance use for personal, or substance possession for personal use, it's a really important response that's needed, but I actually don't support it because of thinking it's going to have direct implications on avoiding opioid-related deaths. I support it for other reasons. I think if we want to address opioid-related deaths, we need to look at what is in the illicit supply and what kinds of responses and supports do we have for people across alternatives to this unpredictable supply, access to treatment in various ways, having culturally appropriate land-based options for First Nations people, having access to services that are accessible to youth and young adults who often don't really feel comfortable accessing services in other spaces, for women and pregnancy and parenting people who can't really access treatment because they don't want to bring their child to a pharmacy every day to get their methadone dose. These are all things that we're not always really adequately, I think, building into our responses, and I think those are the places where I think we can best support people tied to decriminalization, which will, I think, have benefits in other spaces.